viable tissues. Moisture management, we have seen that it is very key not to keep our wounds so dry and not to keep them so wet. Monitor infection by checking on the systemic signs of infection. And then if there is systemic signs of infection, it is always good to put the patient on systemic antibiotics. But if there is no systemic signs and symptoms, it's always good to use topical antimicrobials. Patient education is very key. And not only the patient's education, but also the caretaker's education, because some of these patients go home with the wounds to continue care at home. So it is important to educate the patient, especially on adhering to the wound schedules, wound dressing schedules, observing and reporting any sign of infection, and any changes from the previous dressing, so that you can be able to take care of it in advance. Follow-up care, always give your patient a follow-up care to come back to the clinic so that they can continue the follow-up care of their wounds. Then we come to advanced dressings. What do we expect from advanced dressing? Or what are some of the advanced dressings? Some of them are absorbable dressings, which helps us to maintain the light moisture on the wound bed. They will absorb quite an amount of the exudate, and those are the foam dressing, hydrofibers, and arginates. Others will release medication. Those are the antimicrobial dressing. We have quite a number of them in the market. And most of the wood dressings, when they are due for change, they will change the color, or there is a demarcation of showing that the dressing has soaked enough. They are supposed to reduce infection, to help us to reduce infection and protect the fragile skin without further damage. They are supposed to be conformable to the wood bed. When they are conformable to the wood bed, there's no soaking of exudate, and so the wood will not get macerated. They are supposed to be smart and targeted to help in healing of the wounds. For many years, we have used Goslow, thread bandage, and oxide strapping. That's what we learned in our basic nursing. And we have used them faithfully, and we have taken care of our patients. But at the moment, there are quite a number of advanced wood dressings whereby the wear time is increased. Most of the times when we used to use the gauzes, we used to do BD and PLN dressing, especially for wounds which has high exudates. But today, we have wound care materials or advanced wound care dressings that can stay on the wound even for a week. Most of the times, you'll find ourselves doing our dressings alternate days, after 5 days, after a week, depending on the assessment that we have done on the wound and the exudation of the wound. So as you can see that diagram, you can see up there we have Inadine. Inadine, we have Act Soap. Inadine is a treated dressing impregnated with iodine. We have Act Soap, which is a charcoal impregnated dressing. So it will help, it has silver, so it will help in as an antimicrobial dressing, and also it will take care of odor. Then down there we have a foam dressing there, Better Foam. That one is just a plain foam dressing, so it will help us to manage highly exudating wounds. Down there we have antimicrobial dressing, which is an antimicrobial dressing. So it will donate antimicrobial to the wound, and also it will serve as an absorbent dressing. These are some dressings that they will go, if you can put them even for a whole week if the wound is not highly exudating, or you can use them like when you're doing compression bandaging, because you have to take care of the wound first before you do the compression bandaging. They are dressing that can be left on the wound for even a week. At the corner there we have Aquacel or hydrofiber dressing. It is a silver dressing that will help us to take care of infection. It will also be used in highly exudating wound. It also donates gel, helping us to do autolytic debridement on the wound. Those are just but a few that were there for us in our institution. This is when we started. This photo was taken when we started our wound ostomy and continence clinic. That is the stock we had, but we have had continuous supply of these dressings, even in our ward level. There, I just wanted to show how we used to have patients from theater, the first diagram. You can see it looks a bit messy, but with advanced wood dressing, you can see how the dressing looks neat. And this one also improves the patient's quality of life. When they see the dressing is not oozing all over, they are not soaking, they feel great. So let's do some cosmetics as well as when we are doing our wound care. I've seen people having a small wound on the foot or on the hand, and putting and dressing the whole hand. Yet there are small dressings you can put on that wound, and they look cosmetic, and the patient's quality of life improves. Then we go to negative pressure wound therapy. This is one of the advanced therapies that we have in wound care. Before we trained, we rarely had vacuum. By then, we used to call it vacuum dressing. And if it is recommended, it will take some time for the patient to get the dressing. But at the moment, most of the wound care nurses are able to use the vacuum, the negative pressure wound therapy on our wounds. Think of it like a gentle vacuum cleaner for the wound. So it has controlled pressure, and a special device is applied to control the suction, and the wound is sealed on top so that that pressure can be maintained. It helps us in deep wounds, infected wounds, or slow healing wounds. It facilitates the healing. It also helps us to take care of the bioburden, keep the wound clean, and control exudates, encourage new tissues to grow, which is granulation, and promote contraction of the wound. And also, there is a recommended pressure, which is 75 to 125 millimeters of mercury. So sometimes I've seen people trying to put negative pressure wound therapy, and they are not sure of the pressures they're supposed to use. So please, if you are not sure, always consult, because you can distract the tissues instead of promoting healing. So those are the machines. At the moment, for institution, we have the current advanced machines for negative pressure wound therapy. Earlier, when I was training, we were demonstrated on how to do negative pressure wound therapy through the suction machine. And when we came back, we actively used them, but we they broke down because these machines are not meant for continuous sanctioning. But now at least we have the right equipment, and we are grateful to our institution for providing that. So we are now comfortable doing our negative pressure wound therapy without fear. Because the earlier sanction machine controlling the pressure was not accurate. But for the ideal one, you just set it and the pressure will not go beyond what you have set. That is just to illustrate that you can use negative pressure wound therapy on different parts of the body. Even on open wound, abdominal wounds, post-operative wounds, it can be used. Then we go to, I want to go to another one because I have illustrated that somewhere else. So we are going to see it. Growth factors and cytokine therapy. This is where we apply substances that stimulate cell growth and tissue repair. The cytokines and the growth factors, especially the one which is used mostly available is the platelet-deprived growth factor. They act as signal proteins at the wound bed. So they help in putting other own body cell, natural cells to migrate to the wound and promote the process of regeneration and wound healing. These growth factors teaches the wound to heal because they stimulate the healing. And an example of them is platelet-derived growth factor. There are some emerging technologies, that is bioengineering skin substitutes. There before we have been having skin grafting, flapping, but these days we have laboratory grown skin equivalents, which are synthetic and biological. They are useful mostly in advanced patients and in the chronic wound or hard to heal wounds like diabetic ulcers and venous ulcers. They are used to promote reappraisation and also fasten wound closure. So for the wound nurses, we work on the wound bed, and when it is ready, we hand over to our surgeons to use the substitutes so that they can close the wound and it closes faster. There are other techniques which are at the experimental, but they are promising, like stem cell therapy, which is used to regenerate damaged tissue and improve chronic wound healing, and also laser and light therapy, which is used to promote cellular activity. They reduce inflammation and accelerate tissue regenerations. And also, at the moment, I've not seen them being used on wound care, but they are being innovated for that. But they have seen them being used by physiotherapists to reduce pain, for pain management. So at the moment in our country, they are not a hand of them being used for wound care. But I know a company which is investing in it for wound care, but it has not yet been brought to Kenya. So being a breast cancer month, I could not forget to tackle malignant wounds just slightly to know how we are supposed to help our patients, since we usually find that patients with the breast cancer Some of them get malignant woods. And so malignant woods produce physical, emotional stress, even spiritual stress to patients and the carers. Remember, it's not only the patients who get stressed when there is a wound that is not healing, a wound that is smelling, a wound that is highly exudating. Even the people who are taking care of them, they are equally emotionally stressed. And so some of the associated symptoms with malignant wounds is malodor, which is the most stigmatizing issue in malignant wounds, infection, drainage of the wound, which is also very stigmatizing because it is excessive exudation, bleeding, they are liable to bleeding, easily bleed when you're changing the dressing. Then they are painful and discomfortable because some of them are so exaggerated, they are forgetting wounds and the like. So I've just decided to put that slide there to show the presentation of these malignant wounds. It can present as a forgetting wound. It can present as an ulcer, a nodule, or ulnarophantiasis. So you can imagine the site you can see there, that this patient is seeing it daily, and it's not healing tomorrow. So most of the malignant wounds, when you are doing wound care, you have 3 goals. And the most important one is healing of the wound. If you are not healing the wound, you are maintaining the wound. And if you're not maintaining the wound, you are giving palliative care. And for most of the malignant wounds, what we do is palliative care. And when it comes now to palliative care, we manage the symptoms. We use multidisciplinary team. We take care of the psychological well-being of this patient and his relatives or her relatives, and also the patient's and family goals. You have to involve the patient and the family in taking care of this wound because they are the ones who will be having to take this care of this wound, because most of them we teach them to do it at home. So I want to go back to this slide where we have seen the symptoms. Malodor. What do you do with the malodor? We have several type of wood care material dressings or materials that can take care of odor, like the one I had shown there up, like soap. It can help us to control odor. The other thing we can do is, like for malignant wounds, sometimes we advise our patients to use fragile tablets. They crush it and spread it on the dressing that they are putting on. And it really helps in controlling the odor. The other thing you can do, most of these patients, when they are at home, they are left in their own room there because nobody else wants to enter there because of the smell. Just use charcoal. Put charcoal in a container, maybe a basin, a bucket, and put it in one corner of that room. And you'll appreciate the way the air will be freshened. And also, ventilation of the room is very key to maintain odor. When it comes to infection, you have seen that we have several types of dressings that can help us to take care of the infection. For the drainage, use absorbable wood care dressings. But for this case, sometimes if the wood is in an area that you can be able to apply something like a diaper, because of expenses, they help us a lot, especially for the breast wounds. The diaper will hold on the wood very nicely, and then the patient uses a blah to hold the dressing. And the diaper can stay for quite a long time. Like even you can be changing daily. It's depending on the exudate. If it is not so exudating, it can stay there for 2 to 3 days. But if it is so exudating, you need to change it daily. For bleeding, we are advised to use dressing materials that do not adhere to the wound. And if you don't have such dressing materials, you can use some dressing like toilet dressings, which are not so expensive, just to protect the wound bed, so that when you're removing your secondary dressing, you'll not cause bleeding, because these are some kind of wounds that bleed profusely. Then pain management, as I had said earlier, don't take care of a wound without considering the pain management. We have the scales that we use to assess pain management on patients. Please assess, and if the patient is having moderate to severe pain, ensure that they are on pain management drugs. So as we wind up, I have a takeaway home for us. Advanced wound care focuses on faster healing, reduced complications, and better patient outcome. Some of the techniques used, we have seen them through: negative pressure wound therapy, advanced dressing, growth factors, biological skin substitutes, stem cells, and others that I've mentioned. For successful wound care, comprehensive wound assessment is key. Infection prevention and control is key. Moisture balancing is key. Multidisciplinary team is key. And patient-centered care. How often do you ask your patient how they feel about their wounds? Some of these patients are the ones we have seen, they have very stressing wounds, like malignant wounds. Others have wounds like venous, leg ulcers, diabetic wounds, which are very complex wounds, which are wounds that stays for many days without healing. So they disturb these patients psychologically, physically, socially, emotionally, and spiritually. How often do we allow this patient to tell us about their wound? How often do we usually take suggestions from the patient? From today, I urge all of us, before you take care of that patient, ask them, how do you feel about your wound? What would you want me to know about your wound? They have very good stories in their woods. They can give you a lot of stories that will lead you to do a management plan very well. So let's listen to our patients. Let's take care of them. Be passionate on this specialty, and we will always be blessed. Key message: use the right technology for the right wood at the right time to optimize healing. Last but not the least, I cannot forget to advertise where I work. We are having 3 months stomach, wound, and continence training in KNH School of Nursing. The intakes March, July, and November. The moment we are selecting for November, if you are there and you want to join, just go to our website and apply online. Thank you. I want to acknowledge my boss, Dr. Mweti, who has given me who have allowed me to come and talk to you and educate you. I want to appreciate Kenyatta National Hospital for giving me the chance to come and share my knowledge. Thank you so much. Any questions? All questions are appreciated. I'm ready to answer what I can. Thank you.
Wow, that was awesome presentation. Many congratulations for articulating the issues of wheelchair very well. So there are few questions. You answer the ones that you managed to over the interest of time, and I think we'll start from where you just ended about the malignant wounds,
Yes.
the odor, the smell,
Mhm.
about the use of charcoal. Rebecca Mushiri is asking, do you use just dry charcoal in a container to contain the bad smell, or it needs some manipulation
It is the name.
in the charcoal, the use of charcoal?
Okay. To answer that question, we use dry charcoal, just the way you have taken it from the bag. And for the reddies, I have more tip on charcoal. You can use it even in your refrigerator. If your refrigerator is smelling, just put charcoal with a plate in the refrigerator and it absorbs all the odor. Dry charcoal, put it on a container and put it in that room of that patient who is having a smelling wound. Thank you.
Wow, that's very nice. Rebecca, I hope you have gotten that one. Anonymous is asking, is there a role of honey in wound healing?
Yes. On this mass, honey, we have wood dressings that are honey impregnated or honey gel that it is medicated, it is tested. In Kenya, I know there was a research which was going on. Unfortunately, I've not been able to follow it. It was being done by some doctors about our honey from Rakanivi. So we need to follow up and see and get to know what was the results of that research. But honey is used in wood care. It is packaged in medicated honey, and we are using it in wood care. Please don't go to the supermarket and buy honey and put on the wood. Maybe if you have nothing else, you can use honey that you know the source. Ile unajua pahali imetoka. It has not been contaminated. It has not been added other things on it. It can help. It is an antimicrobial and it also help in debridement of the wound.
Wow, thank you so much for that. And we helped Dorcas Sikoria. She's asking for negative pressure therapy. How many sessions are needed?
As I said earlier, each wound is individual. There are some woods you'll do 1 or 2 negative pressure and you achieve what your goal was. So it depends on the type of wood and what was your goal when you decided that this wood needs negative pressure wood therapy. So it depends on individual woods.
Sure. And also Kennedy is saying, kindly comment on the use of paraffin loaded gauze in wound management, and also the role of culture and sensitivity test for treatment.
Okay. Thank you, Kevin, for your question, which is varied. Paraffin impregnated gauzes, we have different types of them. There are those that are plain paraffin, which are just used for woodbed protection. There are those that are antimicrobial impregnated. They are used to protect the wood and also give an antimicrobial effect on infected woods. On the role of culture and sensitivity, it is important, especially for the chronic woods, to do culture and sensitivity, that is a wood swab. And on that matter, I want to say there's a difference between a pus swab and a wood swab. A wood swab, you have to clean your wood first and then take a swab at a level or an area where there is viable tissues. Why? Because we are trying to get to know the microorganism which is inside the tissue, which is causing the infection. But when you do a wound swab, you correct dead tissues, and most of the times it will give you a negative result. It will tell you no organism found. So it will help you to know the type of microorganisms that are invading your wound, and it also gives you the option of microbials or the systemic drugs that will cater for that specific microorganism.
Okay, thank you so much for that. And the next question, I think you have answered it when you are responding to the above, because it's about what is your opinion on use of honey for moisture balance and as an antimicrobial agent.
I can add something on that.
Yeah.
When I was talking about the dressings, we talked about dressing that donate moisture to the wound, and honey is one of it. It donates moisture to the wound, and it promotes autolytic debridement.
All right. Thank you. Jacinta Casili is asking, what other types of dressing solutions are used in wound care apart from saline solution?
Okay, we have other commercial cleansers like Protasan, which is BHMB solution. That means it has antimicrobial or antisepsis. It is an antimicrobial solution. We have silver solution, which is also antimicrobial. And we have another one called Dakins, which is sodium hydrochloride solution. And they all help in wound cleansing.
So, but the most available, locally available is normal saline.
The most locally available is normal saline and distilled water. But also some of these solutions are there in the market, but they are not cheap. Yes.
Like Protasan.
Like Protasan. But they are very good on infected wounds. Yes.
Anonymous. Do we still use hydrogen peroxide to clean wounds? And if so, do we dilute before you use it, or use it in concentrated form?
Okay. That's a valid question. On my slides, I had talked about what we used to use before advanced wound care came in, and some of them are the hydrogen peroxide, povidone iodine, and the vinegar. I know there are some people who are still using them, but if you go to their literature or the researches that has been done on these solutions, you'll find that, okay, they have beneficial to the wound, but they destruct the cells that promote wound healing, like fibrocytes. So they delay wound healing on the process of trying to control infection. So sometimes if you have nothing, you can, and the wound is very colonized or very infected, you can use them for the first phase of your treatment until your wound bed is clean. Like it doesn't have non-viable tissues anymore. Because when you use them on viable tissues, they will delay and torment, toxicate the tissues, and there will be delay of healing. So if it is possible to avoid them, I would say avoid them completely. Use normal saline, use potable water. Use distilled water. At home settings, we advise patients to boil water and put them in a clean container. But boil little by little at a time, not 5 liter or 10 liter, just a liter at a go. And then they clean the wounds with that.
Okay, thank you, Mary. There's an anonymous who is interested in the cost that you have just mentioned, but they're asking what is the cost?
Okay, our training is 3 months, as I've said, full time. Intake March, July, and November. The cost is 40,500 shillings for the 3 months.
All right, 40,000 for 3 months full time. Thank you for that. Omar Godana, elaborate more on wound care using LAVAI or maggot therapy on septic or chronic diabetic foot.
Okay, Omar, that is a valid question, but unfortunately, that is a whole topic. I cannot be able to discuss it here, but we have an institution that produces the larvae for us, and you are supposed to know the size of your wood for you to be able, for them to calculate for you how much larvae you are supposed to use to take care of that wood. It takes 48 to 72 hours for the maggots to clear your wood. I think that is the much I can add.
Oh, yeah. I know that you have mentioned the role of honey on wound care. Kefa Otieno is asking, does sugar has any role?
I will not comment on sugar because I've not seen any research done on sugar. So I will not be able to comment on that. I have no information about sugar. Somebody is asking whether we can use transformer oil to apply on our wood or burns. I know this is something that is used in our communities, but there is no evidence of what it does to the woods. So I will not comment on that either.
I think this is a topic that we need to repeat again because for the interest of time is so gone. There are people who still want you to illustrate the commercial dressing materials again, the slide that you had. But I think time will not allow us. But David, you can answer David Durant, who is asking why use Flagell tab instead of infusion on the infusion one to dress.
David, I want to say that why I recommend Fragile tablet is in wood care, we depend much on evidence-based. I've used both, but I've seen Fragile tablet being more effective. And on the person who is asking about the dressing, we have a lot of dressings that we cannot go through them at this moment. In class, we have like 4 topics or more than 4 lessons on wood dressings and solutions. So it is a huge topic.
All right. And for the interest of time, let's answer only this one. Last one, Onesimus, is what are the entry requirements for the 3 months course?
Okay. The entry requirements is you have to be a clinician with a practicing license, a certificate from a body that governs your practice, a Form 4 certificate, your ID, and a college certificate where you trained.
All right, and then they apply by our website. Huh?
Yeah, they apply by our website.
I think that's good, Mary. Thank you for taking us through this nice presentation. I look forward for the next presentation on the same, and especially now, like somebody was mentioning that you mentioned something about the venous ulcers. I think that's a whole topic for the team.
A big topic
to discuss that we might even be required to break it at least twice. So we'll organize for another session soon, if not next week, maybe next week part 1. So thank you so much, attendees, for attending, and thank you, Mary, for that information. But for our KNH team, just a reminder that the dressing materials are in the store. You can order them from Pharmacy 40. We have paraffin gauze impregnated with chlorhexidine, the 10 by 10 and 10 by 40. Transparent IV dressings, 15 by 20. Transport tapes, that is the very nice strapping, the transport. It is there, the 2-inch. And then we have the wide area fixation dressing, that is the non-extensible dressing of size 10 by 10 and 5 by 10 is there. Then post-operative dressing, 10 by 25. That is the one we usually call it island dressing. And also we have adhering dressing, that is cellulose, the one we call adaptica, the one that does not stick on the wound. Then we have the hydrocolloid sheets, 15 by 15 centimeters and 20 by 20 centimeters. We also have non-glycerin dressing, that is the silver. It is there 10 by 10 and 20 by 40, and the hydrofibers with silver sheet dressing the Aquacel AG Plus. We have the size 10 by 10, 20 by 30, 15 by 15, and again, collagen is still there. So you need these ones. We're also going to send this list through our principals so that you can know they are there and the exact names that you need to call them from the system in order to get them. So request for them, order them, utilize them, and at the end of the day, remember to bill the patient. So Mary, I think that's what you had to say. Do you have any closing remarks?
Not really, but I want to thank all the attendees for listening to me. I'm very grateful and I'm proud to share my knowledge for the sake of quality of care to our patients, improving our care on wound care, stomach care, and continence care. I think the next topic I should talk about is continence because most of us avoid that topic, either to our patients, to ourselves, and even the community. We need to educate our community on continence matters because there are solutions for them and they can get helped. Thank you so much for listening.
Wow, that's a good topic. We should organize for it. And therefore, take this opportunity to thank our research department for organizing and convening for us this meeting. For the facilities, we are very proud and we are very grateful for always hosting us. And to the nursing standards department, Jane, who speak up. Thank you for the good work you keep doing, especially on organizing a nursing series. And for this session, the nursing standards, they have organized for CPD token for the members who have attended for more than 30 minutes. So we will have the token. So after this, we'll get the attendance list, we'll get your email addresses, and then we'll send them to you. If you have an issue, you don't know how to upload it well, just reach to us and we shall help. Otherwise, thank you so much and have yourself a lovely afternoon. See you in the next session.
Thank you.
Thank you. Bye.